I'm grateful to the organisers too for their support. I normally start presentations like this with a reference to Woody Allen, but he has fallen out of favour in recent months. But he still made some wonderful movies. One of my favourites is Annie Hall from 1973. And in the opening shot of the movie, he tells an elaborate joke about two elderly New York ladies who escape the heat and dust of summer in the city to go to a resort hotel, rather like this one. And though they know each other well, they don't realise they're in the same hotel until the end of their fortnight. And they meet up and exchange pleasantries, and one says to the other, "Isn't the food awful here?" "Well, it couldn't be this hotel, could it? The food's good here." "Yes," she said, "and aren't the portions really small?" And of course, Woody was making a metaphor about life. Life is short, and it's a vale of tears. And it's rather like now this evening, I've only got 20 minutes and I'm to solve all the problems of emergency departments. I'm going to take a system approach and emphasize the importance, the prime importance of developing leadership at all levels in the organization. That I view as a prerequisite for successful delivery of high-quality services. Firstly, I bring a message which might offer some assurance and be depressing at the same time, and that's that healthcare systems across the world are broken and failing, or at least so according to the staff delivering them. Why is that? Right, so it's really because across the world, healthcare has to operate within an iron triangle. We're held in the grip of this. We have to do three things at once. We have to ensure safety and quality, provide access, responsiveness, and deliver rising expectations, and of course control costs and improve productivity. And in recent years across the world, that triangle has been shrinking. It is enclosing health systems in an increasingly iron grip, and all organisations are struggling to stay within that. In Northern Ireland, I think to my shame, in recent years, they've given up on a great deal of the work that had been done 10 years ago when I was a chief executive on access, on waiting lists, on responsiveness, and concentrated on trying to deliver safe services that are within a cost envelope. In the whole of the United Kingdom this winter, sacrifices were made and failed to live within that triangle because elective lists were allowed to extend, so we now have the longest waiting times in living memory for many healthcare workers. Portugal and the UK have many similarities, and it's quite interesting to compare the two. They have similar GDP as a percentage, expenditure as a percentage of GDP, a little below the UK average, but the European average is skewed, is biased by the fact that France and Germany spend a remarkable 11% of their GDP on healthcare. The UK has a length of stay, LOS, that's shorter than the EU average by nearly a day. But of course, on the other hand, there are grave concerns about high bed occupancy. The UK has one of the lowest levels of doctors at 3.8 per thousand population, an average number of nurses. Portugal, on the other hand, has much higher than the EU average for doctors, but lower than average for nurses. The UK has remarkably few scanners compared with the EU average. So the EU mean here is 21.5 for CT and 15.4 for MR. So the UK has more than a half of our less than a half, I should say, of the number of scanners compared with the European average, and certainly far fewer CT scanners than in Portugal. So this might be interesting in a sort of academic sort of way, but I don't think it leads to any deep understanding of the challenges that our two countries face. Too much depends on local context, on models of delivery and skill mix. And so we need substantial caution in interpreting this data. I want to look now at what Sir Brian Jarman, an emeritus professor from Imperial College in London, says about the English or the UK health system. You might remember that Brian Jarman is famous for developing standardized mortality ratios, and these were used to uncover scandals of really poor clinical performance with very poor outcomes, avoidable deaths in a number of hospitals in the UK. And he notes that since 1989 there's been a 40% increase in admissions with a 31% decrease in beds over the same period. That bed occupancy across the UK and particularly in England is well above the 85% maximum recommended. And those of us with long memories will recall that we had to live through a scandal of healthcare associated infections, C. difficile and MRSA, and I've no doubt that the very high bed occupancy and hot bedding contributed greatly to that worrying rise in healthcare associated infections in the 90s and the 2000s. So he quotes the European Health Consumer Index 2017 and notes that the UK is 17th out of 34. It's a remarkable coincidence that Portugal is joint 17th with the UK. And he notes that the UK has never been in the top 10 in Europe, and the report quotes this because of poor accessibility, in other words, long waiting times, and an autocratic top-down management structure. I was president of my professional body for 2 years in year 2000 to the year 2002, and there was a Secretary of State, the Chief Minister for Health in England, a man called Alan Milburn, and when you talk to him, he really did believe that he was the only person out of the 1 million people who worked in the NHS who should have good ideas. No one else was to have a shower that morning and think, today I will do this as an improvement. He was the only one who was to have good ideas. That was an epitome of this autocratic top-down management culture. On the other hand, the Netherlands are almost always first in this consumer index. And again, it's thought that this is because local healthcare decisions are made by medical professions with patient co-participation. In Northern Ireland, we would say co-production with patients. And just as an aside, he makes an interesting reference to the two main systems of funding health services in Europe. He quaintly calls them the Bismarckian system and the Beveridge system. Bismarck, of course, the founding father of social services in Europe with his pensions, long before the UK introduced old age pensions. And of course, a system where there are a multiple number of independent payers for healthcare, and you join a particular health insurance company. And the Beveridge system, named after the civil servant who drew up the welfare state for the United Kingdom during the Second World War, where if there are separate payers, they're all part purchasers and providers of the same organization. He says, the report says there's a clear trend that Bismarck is winning over Beveridge. What we can be sure about is that things in the UK will get worse over the next few years. most clinical staff in the United Kingdom believe that quality and safety of care will continue to deteriorate. Winter almost broke A&E services in the UK this year, and a key factor has been the continuing reductions in expenditure on social care, so blocking the backdoor exit from hospitals. Here's Jon Snow of the Starks of Westeros from Game of Thrones, the actor's Kit Harington. Of course, it's filmed in Northern Ireland, and many familiar landmarks in Northern Ireland are used as backdrops. And of course, one of the themes of the blockbuster is winter is coming. There's going to be several years of continuous winter. And there's great concern in the UK that the traditional dip in performance each winter is beginning to extend throughout the year, rather like the Game of Thrones fantasy. So I want to turn now to some concrete examples in Belfast particularly, where we've taken a system approach to the delivery of healthcare. It was mentioned in my introduction that I had the rare privilege of leading a merger of 6 separate trusts as part of a wider organisational restructuring in Northern Ireland, and I had remarkable freedom to design my own organisational structures and appoint senior staff to fill those structures from scratch. An opportunity given to few of us. I was determined to use the new structures I designed to help integrate the new organisation and improve a focus on patient care. So I'll give a couple of examples. I appointed a director of older people, medicine and surgery, an interesting combination. I should add, of course, that you know that since 1973, social care has been delivered alongside healthcare and is not, like the rest of the United Kingdom, the responsibility of local government. Of course, that's only half the story. Frankly, throughout the 70s, 80s and 90s, they were run in the same organisation but parallel and separate because of the sensitivity of the social work profession being overtaken, being swamped by the medical profession. So they had separate funding, separate organisational structures, and it's only in recent years, driven by the need for reduced costs and increased performance, that we've tried to grasp the opportunities that Northern Ireland has for greater integrated care. This director had a multi-million-pound budget to manage a complete spectrum of support for older people in their own homes, to intensive community support for more frail elderly, to 3 emergency departments in Belfast, 3 A&E departments in Belfast, and all of general medicine and general surgery, or at least that bit of general medicine and general surgery that deals with general emergency admissions. So the director's task was to flex, to bias the organisation away from inpatient solutions and to seek solutions that were outside hospitals. And she had a multi-million-pound budget to do that. She had in-reach community nursing teams who liaised with ward staff to prevent admissions. One example was given to me of an elderly lady with COPD, chronic obstructive pulmonary disease, and she was well supported in her own home by community nurses, and she had far fewer admissions this year than in previous years because her experience had been that every so often she would have an acute episode and be admitted to hospital through the emergency department. And this weekend her son was visiting her and he was distressed by her blue lips. And he took her to the emergency department so that she would be admitted. The community nurse then, as part of her routine tour of emergency wards, in the Royal Victoria Hospital came to her and said, "Why are you here? Why didn't you ring me or a colleague? That's what we agreed would be the protocol." "Oh, my son wouldn't listen to me. He insisted that I go to hospital." And of course, she was discharged home that afternoon with continued support from community nurses. The other thing we did was, there are two large university teaching hospitals in central Belfast. And one has a bias towards cancer and molecular medicine, and the other has a bias towards those very acute services that support trauma. So it was relatively easy to say that the trauma hospital would continue to do increasingly more emergency work, and the cancer-focused hospital would stop doing emergency work and concentrate on this more planned work. So typically then we were able to go further, and typically a general surgeon who dealt with undifferentiated emergency admissions would have a roster that would mean 1 week he'd be working in the trauma hospital dealing with emergency surgery. The following week he would be in the cancer hospital dealing with elective surgery, so that the two didn't interfere with each other. This meant a better focus on patient care, better scheduling, fewer theatre cancellations, and it proved very popular with the 18 or 20 general surgeons who took part in this week about rota. We have a clinical assessment unit for A&E patients who otherwise would have been admitted only for tests and investigations. So rather than go through the front door into a ward, you can be diverted to the investigations unit, which is located close by the emergency department. And similarly, an ambulatory care centre designed to have the capacity to be able to offer urgent admissions for people who could be treated on a daycare basis rather than having to be admitted. And then finally, in these examples, a central control room, so that all the beds across all locations in the trust, and we had these 2 university teaching hospitals, 2 other small acute hospitals, and then perhaps about 200 community-based facilities, about 1,500 beds in all across the city of Belfast. And so the trust was able to maximise the whole spectrum of acuity, so critical care beds, high dependency beds, acute general beds, rehabilitation beds, step-down beds, continuing care beds, so that everything could be integrated. The key to this, of course, is what some people call integrative leadership. And here's a definition: bringing together diverse interest groups and units or organisations in semi or more permanent ways. So again, a few examples from the United Kingdom. In Belfast, I worked hard when I was appointed to run health and social care for the city, to persuade the City Council Chief Executive to offer leadership and chair a meeting of himself, the head of local government, police services, housing, education, and of course health. So we met on a regular basis to work together to deliver Belfast as a better place. And it needed high levels of trust, of course, and you have to choose your early wins very carefully so that people feel that the time is worthwhile. The English have been working hard on their sustainability and transformation partnerships. They're battling against the wind because they're seen fairly overtly as vehicles for saving money rather than reform. I think they were badly sold a few years ago, and there's quite a bit of resistance. And quite interestingly, in Scotland, very recently, they've moved to establish 3 regional partnerships across all public sector to better integrate, to solve wicked problems like A&E across the whole of the public sector. An example of improving public sector cohesion. So I'm going to suggest to you that the overarching problem is that the environment for hospitals and health systems, the context for hospitals and health systems, is changing faster than organizations up to now have been able to change themselves. So here's Helen Bevan, Chief Technical Officer of the Horizons Group for NHS England, and she reminds us that 70% of big organization-wide top-down change fail. It's a remarkable figure. Why would anyone attempt to do a big top-down change process when it has only a 30% chance of success? She points to clear global trends, disruptive change, work complexity, digitization, the diminishing of hierarchical power, and change moving to the edge of organizations, and suggests that the dominant approach is being replaced by an emerging direction, and transactional management is being replaced by relational management. Here's John Cotter, an emeritus professor at Harvard, and he wrote a book that he called Accelerate, and he talks about the need for a balance between hierarchy and networking, that you need many change agents and many acts of leadership. You need at least 50% buy-in from staff. You want people to realize, to move from having to want to. I despair of a whole range of organizational change which involve only a handful of very top people, and they make broad sweeps and then wonder why the hard slog of organizational change doesn't happen. It's because they've made virtually no attempt to get any sort of buy-in from staff. They don't communicate well what they're doing. They don't give clear, consistent messages. And here's John Cotter saying that 50% of staff must be on board to the organizational purpose behind change. He says we have to treat staff as volunteers, not as conscripts. And if I had a magic wand, it would be to instruct all NHS leaders to live the treatment of staff as volunteers rather than conscripts. I'm sure there's a Lidl in this town, and Lidl pay a higher rate for shelf stackers than we pay for entry-level staff, cleaners and porters. Why would anyone work in a big hierarchy where they're not valued when you could work for an organization like Lidl or Aldi where they pay much better? He talks about, instead of giving staff permission to do things, you need to encourage self-efficacy. This is a term borrowed from sociology. It really says people with high self-efficacy, for example, if they fail an exam, they will blame themselves for not working hard enough. If you've low self-efficacy, you will say, oh, well, the exam was too hard, or they were biased against me. So what you need to do is, it's not enough just to give permission. You must encourage staff to think that they can do change, and if they think they can, then they can. When we established the Belfast Trust, the Director of Finance explained the financial situation to me and said, should we not create a burning platform using this financial challenge? And after a long discussion, we decided not to, because what you want is to have your 20,000 staff with a burning ambition to do better, and for the leadership of the Trust, the community of leaders in the Trust, to be creating burning ambition across all 20,000 of us. Time? Okay. Right. I'm not going to dwell on this. We'll just skip this. So we were doing a leadership walk around in a ward. This is a technical device to to visit wards, besides the sort of visits I used to make every Wednesday morning to a frontline part of the hospital. And a junior consultant, a GI physician, was talking about hand washing, and he was saying it's not enough to wash your hands between patients, you must be seen to be washing your hands. He said it's a bit like doing your driving test. It's not enough to look in the mirror, you must let the examiner see that you've looked in the rear view mirror before you signal and before you complete your maneuver. And so I thought, well, this is a very useful extended metaphor for leadership. We look at ourselves in the mirror and we think what messages we're giving. We look at our wing mirrors to see what's coming up on the inside. Very often we can't see very clearly ahead. This is a bit like me driving up yesterday from Lisbon in the rain. But you can see where you've been quite clearly. So very often you're looking in the rear view mirror because that's the safest way to see what you have been doing. You have to repeat consistent, clear messages until you're wary of it, because when you're wary of it, some people are only really understanding the message for the first time. In the first year of the new trust, I did 60 what Americans would call town hall meetings, open meetings for staff, where I gave a short presentation of about 15 minutes and then took questions, and all staff were invited to attend. Sometimes it was only 20, sometimes it was 200, sometimes it was very noisy, sometimes it was quite calm. But I kept giving the same consistent message time after time to staff. And I want to underline the importance of honesty and trust. Honesty and trust that are earned through courageous conversations with staff about an uncertain future. My experience is that people much prefer the certainty of misery or challenge than the misery of uncertainty or dishonesty. I just want to end then quickly. We took the opportunity with a merger of 6 trusts to deal with duplication and reorganise the delivery of health and social care in Belfast. We did this less than 18 months into the reorganisation. And we had extensive pre- and post-consultation. We did it in 2 phases. We did a high-level review and then a series of specific reviews that we did in consultation with staff, clinical staff particularly, and the public. So we had a high level of clinical and public buy-in. So, for example, we were able to close one of the 2 maternity units in Belfast. We were able to go from 1 out-of-hour surgery unit to 2. We had 3 emergency departments, we went to 2. We had 3 inpatient mental health units, we went to 2 to 1. And we withdrew our reliance on statutory elderly care inpatient units or community units and relied entirely on home care. So these were remarkable achievements that we were able to do as part of the merger, because we paid a great deal of attention to harnessing the commitment of staff, particularly key clinical staff. In other words, we worked hard to get a community of leaders. I want to end now with 2 quick slides, if I may. I owe these slides to giants of the health service who did consultancy in Eastern Europe when it was emerging from the fall of the Berlin Wall, where there's very intense engagement between politicians and healthcare managers, very similar to Northern Ireland, and I suspect similar to Portugal. So here they are. The first thing they say is, if you're in healthcare management, try and keep the initiative. Exploit the possible and go with the grain wherever possible. Keep in with the outs, because the outs will be in again soon. And bad things happen. Don't get between a dog and its lamppost. And in avoiding the getting wet between a dog and his lamppost, keep the initiative and keep going round this circle. I think it's wonderful advice for people who have to deal day to day with political leadership. I'm going to give the last word to Seamus Heaney died recently, of course, a Nobel Prize winning poet from Northern Ireland, a secular saint. He can make prose sound like poetry. This was an address he gave to graduates at the Queen's University more than 20 years ago. And I think it sums up the challenge that we have in health and social care delivery. Getting started, keeping going, getting started again. In art and in life, it seems to me this is the essential rhythm, not only of achievement, but of survival, the ground of convinced action, the basis of self-esteem, and the guarantee of credibility in our lives, credibility to yourselves as well as to others. Thank you very much.
Manual do